Good evening. Today we're going to talk about the healthcare workforce in the United States in both primary and secondary care. This class will help you to describe the organization, structure, and function of the U.S. healthcare delivery system in terms of financing, insurance, payment systems, and healthcare delivery, to compare the U.S. system against other international health systems in terms of quality, prevention, access, cost, and equity, and to explain the role of and differentiate among the various federal, state, and city agencies and regulatory systems in protecting health. In particular, if we think about our SHE-Quad function model, we started off with financing. Remember, in order to have healthcare, we have to pay for it. So we got a big bucket of money. Most of that went to insurance through a payment mechanism to delivery to the providers, and some of it went directly to the providers via things like co-pays and co-insurance. So we today are talking about the part of delivery for primary and secondary care that involves the providers. So we're going to talk about levels of care. And I want you to note this is different than primary, secondary, and tertiary prevention. We also use those terms. There's a lot of overlap in what kind of care matches what kind of prevention, but they're not exactly the same. We're going to talk about the kinds of providers who render care, and we're going to talk a little bit about shortages in healthcare providers. So there's three levels of care. Primary care, we can think about as things you would go to see your family doctor or your internal medicine doctor, or that you would take your child to a pediatrician for. Prevention, health education, some diagnostic services, treatment of minor injuries, for example, getting stitches, or acute illness such as strep throat, treatment of long-term management of chronic illness once a specialist has stabilized the person. So you can think about managing medications for people who are diabetic or people with heart conditions. Secondary care is more complex, requires more skilled diagnostic services, usually involves some kind of short-term treatment that needs a hospital or other surgical setting, advanced interventions not available in primary care, and specialist providers. Tertiary care is when the person requires care for ongoing complex or specialty services. For long-term services, this is institution-based and conducted by specialist providers. So let's use the example of somebody being screened for colon cancer. The primary care physician or nurse practitioner, physician's assistant would make the colonoscopy referral. The secondary care professional performs the colonoscopy, usually a gastroenterologist. This can be performed in their office or in an outpatient hospital setting. Typically requires, more expertise than could be done by a primary care professional in their office. If the test is positive for cancer, the patient then moves along to tertiary care. So the tertiary care for colon cancer is going to be at a specialized center. It might be at a hospital center, it might be at a cancer center, but it's likely going to involve surgery, chemotherapy, and radiation therapy. After these therapies are over, and even while they're going on, the patient is going to be, it's over, they'll be released and sent back to their gastroenterologist for long-term monitoring and to their primary care physician. Even while the tertiary care is happening, the person may still be going to their primary care physician to help them do things like manage the side effects of the drugs or address any other illness or injury that might come up. So primary care is defined also by the point of entry, by the coordination of care, and by the essential care. And I want to point out that we started off the class talking about the World Health Organization, the Alma Ata Declaration, about the importance of primary care. Primary care, in the big view, involves things beyond simply clinical care by a primary care provider. It involves those providers taking policy action. It involves providers empowering people and empowering communities, and also, of course, functioning as the center of the hub for clinical care referring out to secondary and tertiary care when needed. Now, the goal of primary care is to decrease the risk to a client of disease or dysfunction. The approach is general health promotion and protection against specific illnesses. It's typically first contact care for preventative care and for persons with signs or symptoms or health concerns that are undiagnosed. This is ideally. Sometimes folks will go right to the emergency room for primary care, but that's not really good practice. Primary care also involves the ongoing monitoring and maintenance of care for people with chronic conditions, and primary care specialists will also coordinate care if a patient needs care from several different kinds of specialists. Secondary care is done by specialists, but it's defined by its short-term nature, consultation with specialists, and then advanced interventions such as surgery, chemotherapy, rehabilitation. And the goal is to alleviate disease and prevent future disability. The approach is early detection and intervention. Think about the colon cancer screening example we had. And it's typically provided in outpatient, ambulatory, and short-stay hospital settings. It includes such things as physical therapy and occupational therapy. Tertiary care is really defined by its complexity, and it's needed for conditions that are rare and or serious. Tertiary care is institution-based and technology-driven. The goal is to minimize disability associated with chronic or irreversible conditions, and the approach is restorative. So the idea is to try to restore a level of help to folks, to try to cure them, and perhaps simply comfort activities if restoration and cure is not possible. In any case, the goal is to attain an optimal level of functioning given someone's compromised health state. So this can include things like cancer management, transplant services, severe burn treatment, palliative care, hospice care, and so on. Now, this care is delivered by a team, and ideally, and more so in the United States, healthcare is delivered by a multidisciplinary team working together. And the kinds of professions that we normally think of as being on the team are physicians and nurses, physician assistant, nurse assistants, dietitians, imaging technicians, pharmacists, laboratory techs, occupational therapists, physical therapists, and so on. However, there are other team members that are important, but we don't normally think of them being as on the team, even though they should be. And these are dentists and psychiatrists and podiatrists and psychologists and ophthalmologists and optometrists and behavioral health technicians, dental assistants, audiologists. It's a really bizarre artifact of our healthcare system and also in how we define and reimburse for primary care that people take care of our mouths, dentists, our minds, mental health, psychiatrists, our feet, our eyes, and our ears are not really considered to be primary care taking care of our whole body. Um, and I just wanted to bring that up to point out that these folks are very much part of the team. And we need to really think about ways to change that view. Let's talk about who works in the healthcare force. As of 2023, 2024, the numbers don't change that much, but the numbers, most of them I tried to get as updated as possible. There are 17 million workers in the healthcare industry. This is the largest employment sector in the United States. It's a big deal. So on its own, healthcare is a big part of our economy. 80% of the workforce is female. And this is important because many of the folks in the workforce who do not have advanced degrees and who are more likely to be female are underpaid relative to what they do. There are significant shortages of healthcare providers in many areas, particularly rural areas, but also in parts of New York City. And why are there shortages? There's three main challenges that the entire United States is facing in maintaining the workforce. First, the healthcare workforce is aging. The youngest of the baby boomers are now 60. That was the biggest group of population that, sort of transiting through. In 5 years, they'll pretty much all be retiring. Not only is the healthcare workforce aging, but the population's aging. So we have more people needing more complex care and less people to do the work. There's high levels of burnout and stress in this workforce. People leave, people go and do other things because um, healthcare settings are not really great at taking care of their own healthcare workers. And job satisfaction, by almost every study, has been decreasing for a while in the healthcare workforce in general. So, who are these workers? The number one, the single largest group of workers in the United States are registered nurses, and there are 4 million actively practicing. There are 800,355 physicians who are actively practicing in the United States. There's about 900,000 physicians in the United States, but they don't all practice medicine. And so it's important to look at when we look at the numbers are the ones who are actually providing patient care. There are also 747,000 workers in the oral healthcare workforce, dentists, dental hygienists, dental assistants. Um, this graph, it's the latest one I could find, is from 2019. So I've updated the numbers, but the numbers are roughly, well, the nurses went way up, but the numbers are similar, and certainly the ratios are similar, where, you know, registered nurses, nursing assistants, and personal care aides are really the top three. There's a critical shortage of primary care physicians in the US. So, of those 800,000 physicians actually providing care, we define the primary care physicians as those in internal medicine, family medicine, geriatrics, and pediatrics. Only a third of US doctors who see patients provide primary care. That percentage has been dropping consistently for many years. Again, there's a rise in demand for primary care. We have an aging population, increased number of chronic diseases. The Affordable Care Act was fantastic. It greatly expanded insurance coverage, but with the expansion of insurance coverage came a demand for more primary care. People could now pay to see a doctor. And of course, COVID-19 and other epidemics that have come through. Some problems. One of the reasons there's a shortage, our primary care physicians earn 42% less than specialists, and arguably have a higher workload. Now, we do have nurse practitioners and physician assistants to try to fill the gap. Over half of all primary care providers are nurse practitioners and PAs, but they don't fill the gap, and there's still a shortage. So, primary care physicians are important because they are the backbone of ambulatory care. Ideally, think back to the World Health Organization, the Alma Ata Declaration. We want all care to come through primary care. We want people to first come to their primary care providers and then, when needed, be referred to secondary and tertiary providers. And in 2004, 85% of all adults had a visit with a doctor or other healthcare professional, and 95% of all children had a visit as well. 500 million visits were made to primary care physicians in 2024. This is half of all physician visits. Ideally, we'd like it to be higher than that. But let's talk about the care shortage. So if we look at, there's different ways to look at health provider shortages, and I'll talk about them in the next few slides. So we have something called, health provider shortage areas. 80 million people lived in a primary care shortage area in which there were not enough practitioners to serve the needs of the population. 60 million people in the United States live in dental health professional shortage areas in which there are not enough dentists to meet the needs. And for mental health, it's even worse. 123 million people, near over a third, in the United States, live in areas where there are not enough mental health practitioners. And when we talk about primary care shortage, so we'll focus on that for now. A quarter of the US population lives in a HIPSA. And how do we define them? They're defined by geographic areas. So first, what is the population to full-time equivalent primary care provider? And the ratio has to exceed 3,500 people to every one full-time equivalent primary care provider. So this assumes that each primary care provider wants to have a panel of 3,500 patients. That's a fairly large panel. It also is based on travel time to the nearest provider. So there are rural counties in which the county may have a better ratio than 35,000 to 1, but it still may take too long to get to the provider. We also define HIPs based on population groups. So there may be existing barriers to accessing care, socioeconomic, cultural, linguistic. There may be providers in the area, but not providers that accept Medicaid reimbursement, in part because Medicaid reimbursement is really low in a number of states. And it's just important to note that Native American indigenous tribes are universally recognized as a population group health provider shortage area. They automatically get that designation. And once designated as such, that opens the door to be able to get help and support from the federal government towards remedying the shortage. So if we look at the map of the United States, um, HPSA scores basically 1 to 13 is there's a mild shortage. 14 to 17 is considered a moderate primary health professional shortage area for primary care. And 18 and above is considered a severe shortage. So you can see, and I'll show you in a minute something that's really interesting, that the shortages, exist in the South, along this deep South belt. They exist along the spine of the Appalachian Mountains. They exist in areas with heavy Hispanic populations and also with heavy Native American populations. Um, and there is a disparity here. So if we look at what is sometimes termed the Black Belt in the United States, and this is the mid to deep South, where there are counties that are majority Black, 50% or more, um, Black alone, or in combination with folks who are part Black mixed race by census definition. Look at this belt and look at the belt of severe health professional shortage areas and notice the overlap. That's a big disparity in access to primary care for Black people living in the Deep South. So New York's not exempt. You would think New York City has so many hospitals, so many doctors, and yet even in New York City, we see both moderate and severe shortage areas, particularly in parts of Staten Island, most of the Bronx. Actually, that may be just about all of the Bronx. Half of Manhattan. What we're looking at is Harlem, right? Harlem and East Harlem. Parts of Brooklyn, parts of Queens, and you know. So even in New York City, where we know we have the doctors, their shortages. If you want to know more about the scores, they're developed by the National Health Service Corps. You can go to their website. If you want to go ahead and build your own map, if you're in a different geography and you're curious as to what health provider shortage areas look like in your area, you can go to that website from HRSA and build your own map. So let's talk just for a minute about secondary care. In this country, 68% of physicians are specialists. It's a lot of specialists. 500 million outpatient visits each year are specialists. Again, that's the other half of all visits. Why are there so many specialists? Most of the countries do not have this ratio of primary care to specialists. Three things. First, rise of hospitals, right? So as more and more hospitals were built, more and more specialists came to be trained. Medicare pays for graduate medical residencies, but does not regulate what the residency has to be. And the teaching hospitals in which these residencies are located typically choose to have more specialty residencies than primary care, in part because it's easier to fill specialty residencies. Um, Medical school is expensive. Some people go into medicine to make money, and you're simply going to make a lot more money as a specialist. So there are all kinds of primary care reforms, all kinds of policies trying to reduce the primary care shortage. And not going to spend a lot of time on this slide. I know it's busy. I'd encourage you to look at it on your own. You can go to a couple of websites to see what's happening with the expansion of federally qualified healthcare centers. The Affordable Care Act had a fee bump, temporary bump increase in Medicaid provider payment. There's new incentives that are being offered for care providers working in underserved area. There was the establishment of the Center for Medicaid and Medicare Innovation Center, and there are all kinds of partnerships. So again, this is beyond the level that we're going to talk about in this class. But if you're interested as to what we're doing about this shortage, these are some resources you can explore. And finally, next up, we will be talking about hospital settings.